Next paper will be presented by Dr. Schläger, the thoracoscopic CDH repair after Ecmo, benefits, risks, and rates of success.
Thank you for the opportunity. We have nothing to disclose. Approximately 10 to 20% of patients with congenital diaphragmatic hernia require Ecmo prior to their repair. Currently, there are no reports in the literature evaluating thoracoscopic CDH repair in the post-Ecmo patient. There are likely a few reasons for this general refrain. Firstly, it's the practice of many institutions to repair their patients while still on Ecmo. That's generally done in an open fashion, so for those institutions, it's pretty much off the table. However, even for institutions such as our own, which are generally in the practice of performing the repair post-decannulation from Ecmo, thoracoscopy is oftentimes not attempted, probably out of two major concerns. One, the concern that a post-Ecmo CDH patient won't tolerate the necessary thoracoscopic insufflation pressures, and two, the expected defect size in these patients is assumed to be so large that it'll preclude a thoracoscopic repair. The goal of our study was fourfold. Firstly, to review the overall rate of success of thoracoscopic repair of CDH post-Ecmo. Two, evaluate whether thoracoscopic insufflation pressures can be tolerated in this patient population. Three, determine the reason for conversion when it was necessary. And four, evaluate the potential extubation benefit for patients completed with a thoracoscopic approach. So we performed a retrospective review of all patients who underwent post-Ecmo Bachdel CDH repair between 2001 and 2015. Excuse me. Demographic data and outcome data were collected for all thoracoscopic attempts. I think we went ahead one slide. Let's see if we can go back one. All right. Demographic data and outcome data were collected for all thoracoscopic attempts. Outcome data included rate of conversion, reason for conversion, intraoperative end-tidal CO2, time to extubation, and rate of recurrence. So, as you can see, thoracoscopic repair was successfully completed in 6 out of 21, or 28.6% of the patients. Demographic data between the two groups were compared, including prenatal diagnosis, gestational age, age and weight of repair, length of Ecmo run, and the need for a patch, collected for both the open and thoracoscopic group. And as you can see, there is no significant difference between the two populations for any of these parameters. So, getting to the important part, the reason for conversion. So the bottom line is the reason for conversion in all 15 cases were defect size. It would appear that all the patients tolerated the standard insufflation pressures. In the intraoperative reports, 10 of the 15 actually reported that the patient tolerated pressures between 3 and 7 without any difficulty whatsoever. 4 of them didn't comment, and only one patient, it was noted that the patient didn't tolerate when the insufflation pressure was turned all the way up to 8, and that was used as a method to reduce the hernia. However, generally, we use a pressure of approximately 3 to 5. So nevertheless, even in that case where the patient didn't tolerate, it was noted that the ultimate reason for conversion was actually also defect size. This is a measurement of the overall intraoperative end-tidal CO2 over the course of the case. They ranged in both groups from approximately 31 millimeters of mercury to 51, with no significant elevations during thoracoscopy. As you could assume, the beginning will be most of the thoracoscopic group. This is completely thoracoscopic. And here, the conversion probably happened at different times over the course of time. But even in the beginning, when they're all thoracoscopic, there was no significant elevation in the end-tidal CO2. They all appear to tolerate standard insufflation pressures. So, the extubation data. The average time to extubation for the thoracoscopic group was 5.6 days. This is compared to 19.4 days in the converted group. This data is consistent with the data from the CDH registry, where the average time to extubation was 16.5 days in the post-Ecmo population. Of note, one patient in the thoracoscopic group expired on postoperative day 3 and therefore had to be excluded from these results. Additionally, there's no difference in the overall rate of recurrence. Now, the follow-up on the different rates of recurrence will be different for the different populations, but they should overall be somewhat equal over the course of time. The rate of recurrence was equal in both populations. So, in conclusion, thoracoscopic repair appears to be both safe and feasible in the post-ECMO patient. Standard thoracoscopic insufflation pressures are generally well tolerated in this population without undue increase in end-tidal CO2. And finally, and probably most importantly, in addition to the avoidance of the morbidity of an open repair, whether it be scoliosis in a thoracotomy or adhesive obstructive disease in a laparotomy, thoracoscopic repair also provides a significant decrease in ventilator days in this patient population. Although further investigation with greater numbers is required to confirm our findings, our outcomes suggest that at least an attempt at thoracoscopy in the post-ECMO CDH patient is well tolerated and can have significant benefits. Thank you.
Paper's open for questions.
Do you repair all your babies in the OR, or do you do bedside repairs in the NICU for your CDH patients?
So we repair most of the babies in the operating room. The only babies that we'd repair at the bedside were ones that were deemed so unstable that they wouldn't be able to make it to the operating room. So some of the patients who were excluded were the ones that were never attempted for thoracoscopy because they couldn't leave the unit.
Right. So all the cases you did with thoracoscopy were in the unit?
We're in the operating room.
Operating room. Okay, thanks.
Hey there, I was wondering if you had a sense of the risk stratification of the different CDH patients, such as defect size or prenatal lung volume. Because it could be that the kids who extubated earlier are just better CDHs. There's obviously a big spectrum.
I'm sorry, there could be the kids that
Extubated earlier were just patients who are on the milder end of the spectrum, even though they did require ECMO. All the patients that you were able to complete, or the other ones you converted, were large defect size, which probably goes along with smaller prenatal lung volume.
it's possible that small prenatal lung volumes, we don't have that information. I don't think defect size would necessarily play a part because in the end, as far as they're probably all covered over. But I think prenatal lung volumes is possible to attribute it. All the other factors as far as ECMO run and other baseline facts about the patient which would yield instability were all equivalent. But I think it's fair to question the prenatal lung volumes.
Yeah, no, most CDH studies now risk stratify A, B, C, D on defect size, which corresponds with lung size.
So I think those are very hard to follow. We've looked at those, and I think there's a lot of, even within our institution, there's a fair amount of variability about how those things are categorized. And so I decided not to use those in there.
Rothenberg?
Great report, thank you. But I'm trying to ferret out your data in terms of days to extubation. The group that had prolonged days to extubation were the group that were converted to open?
Yeah.
So I wonder about the operative times and the difficulties. I realize you said the reason for conversion was not because the child didn't tolerate the insufflation, but because eventually you couldn't get the defect closed. But what I tend to see happen in cases like this is that you make, and I know you guys would, make extensive attempts to get it done thoracoscopically, then convert to open, then do an open procedure. And so you could have significantly prolonged operative times in babies who might be a little bit prone to convert back to fetal circulation and have other problems. So I wonder if it wasn't a self-fulfilling prophecy that you created a group of patients that took much longer to recover from the procedure, and had those patients initially just had an open procedure, might their days to extubation have been the same as the thoracoscopic group?
So I think that's a very, very fair question. Actually, the data I have is that thoracoscopic group actually took longer than the open group. The average operating time for the thoracoscopic group was 175 minutes compared to 143 minutes in the open group. So the open group ended up making up time and having less time under anesthesia. And despite that fact, they still had prolonged extubation.
I'm afraid we'll have to limit the questions there.
Nice paper. Would it be possible for you to do a comparative cohort or comparative group with neonatal patients being treated with nitric oxide and high-frequency ventilators and previous field surgery with tracheal occlusion with tracheal balloon to do a comparative group?
So I'm not sure I understood the question.
You compare babies who were on or not.
You're just presenting patients with ECMO.
So all the patients in the study were all at some point on nitric oxide and on the oscillator prior to their ECMO run, because that's sort of a standard in our institution that basically they pretty much all go on those things, and all of them were off those two things before their surgery.